along with Dr. Start with the top.
Wondering how to of my hospital. It's in the building is, you can see the old building there, that's 1899. Interventions. Now this is a very standard in claudication. Then we do something like this. What we're going to talk about today, because I'm from the cases that we have also as well what your experiences. So I'll go ahead to Yoda said, there is do or not do, there's no try. What are the newer developments in the field of intervention in the peripheral territory over the last decade? So this is the background of a patient that we had who was Yoda up top. Back, and this was a no-go territory for peripheral. So we take a left brachial axis to approach from the top, place a guiding. Here you can see where the reformation, very faintly seen, of the common femoral artery and the bit of the external iliac with a wire. Here we're getting close to the common femoral artery, crossover, and now we are going to address the left side, which we haven't yet crossed. We try from the top. We get in, but when we get close to the CFA on the left, which we have to enter to finish the procedure, we find that we're not able to get across. Now what? Puncture from below now. Balloon, and then it's as usual. You can see bilateral wires, kissing balloon angioplasty, as post angioplasty, and then we place stents. And I'll not waste your time with this. By now it's pretty standard. All of you. Yeah, okay. And we finish with this. This is to illustrate some points. This is the CT extend from the infrarenal aorta. The right axis for the lesion that you want to cross. It must be understood clearly that the job we do is a mechanical job. So the straighter the path you can get to the tip of the wire, the more weight, the more load, the more force you can transmit to the tip of the wire, which directly impacts what you can cross. The longer and more around the corner to the right, but that would have meant we have a more than 90-degree bend. Pick an axis. So we try the cross is not known to us when we start. We can guess, but we don't really know. So if it doesn't work from the top, try from the bottom. And lastly, I'm sure all of you know, you can never have too much support. There's no such thing as too much support. So where required, you take catheter inside a guiding catheter. Through that. You've got an occlusion on the right side. Common iliac above the bifurcation of the common meter. In any case, the right side, and that's a guiding catheter around the corner. Now still occluded that we wanted to reach. Okay. Using multiple short balloons is not as good as using a single result. And then we have. Okay. Yeah, fine. Stop it from there in the meantime. Can we have this running? Angioplasty, you can see the entire. We don't extend side, which was also occluded on the left, and the final angiogram after we've finished on the right. I think the infrapopliteal part is not being seen too well here. Okay. Patient follow-up, 6 months, ulcer healed. So if we, as long as that, so what is the point here? What is the point from this case? First thing is you got to have patience. This case took us 2 hours plus. Okay? Because when you're crossing a long distance, you want to check frequently that you're not going the wrong way. Like in any, usually is whether you should result have a be possible, the surgeon may refuse, but that's a different cup of tea. Okay? So that is a little bit about different axes. There are many lateral, you can go ipsilateral. The considerations that you should have is one, the first one we spoke about, try to get contralateral is usually your problem is you're going around the corner, you automatically have a bend in your path. So that is to be remembered. Once you take a long occlusion, a tough occlusion, a lot of calcification, a long case, common femoral, that makes an obese patient because it's very difficult to get the puncture because your path becomes have in your path. You may need to use a longer experience of antegrade punctures to do them. For these, we'll usually use the cases are all. So this is the angiogram reformed. Blocked. We puncture the SFA. Come from below, and now it's much easier. You can't really make. From below the wire is brought in, past from distal axis, cross from distal axis. That's a larger artery. You can have, and there you are. And how do we close this hole? 5 minutes, 10 minutes. So what is the tip from this? When you can't get axis, okay, 6 millimeters. Use is even smaller, and we'll show you that also. Okay. In SFA or stump, it's a flush occlusion. It's primarily from below, from the popliteal. Why? Because from the top, we can't possibly get an access when we don't have any stump. It's flush. We will not know where to go unless from below. And now this was planned for what we call a subintimal angioplasty. You can see here, note this carefully. You can see the wire curve, and we go up and re-end, and there is the kind of thing you get. You get a very smooth. It's a good technique. It's an so. Subintimal saying, oh, and in an accidental result at the entry point, you may find another patient. Now this is a different kind of thing. Okay, look like right here. The distal circulation becomes. We look here. Look at this now. Please look at this. Can you see that calcification? What kind of situation now? This is the plaque there. Here. There is no stent, no limiting dissection. I'll be forced to place a stent. And a stent in this territory is what we did, followed by ballooning. And, it's a total occlusion of the, again, this is an area where you don't want to put a stent. Case. And then, that's the diploid spider. And then we use a directional atherectomy catheter, that's the Turbo Hawk, which comes in different sizes and a little bit about this. This is the area which cuts directional. So you can turn the device and cut resistant lumen when you do your angioplasty. So after the initial, not to waste too much time with this I'm sorry, it's gone off. A totally clean artery at the end of the atherectomy. We don't know, this is not a very common opening up, removing the plaque, but it tends to get the ulcer or the wound to heal. It provides you that much needed time when the wound, you're okay. So atherectomy may help in cases where standard at the end. If you want a large lumen at the, actually in places where you never want to put a stent. Okay? A stiff device. And when your circulation is compromised, you want to put a filter, patient, but this patient, again now you can see here, very few other options. So you can see here from the SFA, the next reformation is below the popliteal trifurcation. Whether you'll be able to get into this artery, because there you got a trifurcation, it becomes very to decide which small artery you're wiring. Here you can see. So we did a distance, and what we crossed up with, sorry, this video, can you run the video please? Micropuncture wire, the 1-4 wire, and over that we place a microcatheter, a support microcatheter. In this case, on a 3 French microcatheter went up, crossed over. So distal access, it's possible to do this. With the conventional, and with these patients who have more likely you have to have an adverse result. This case was done with some 50 cc of contrast. The post-procedure follow-up color Doppler just shows that the flow is in this case that when you do distal access, you require different tools. You have catheters, you're conventional for this purpose. So you have to change the tools you have. Now, different people use different ones. You can use coronary guide wires if you're comfortable with them. You can use the specific peripheral guide wires if you're comfortable with those, basically. The second point is the most important thing. If you're going in for distal access, never ever damage the distal access. If you damage that artery, then surgery the last few. So this is a case to illustrate a different point. Terribly, the patient had to undergo amputation of the opposite side. This side he was having rest pain. You can see it's terrible. I mean, distal SFA occluded, single vessel runoff, peroneal, dorsalis pedis barely seen, multiple lesions. Just forward this. This is not relevant. Anyway, I'm going to skip this video. Okay, so anyway, we got across the occlusion. You can see we are down in the dorsalis pedis with the microcatheter. What did we get? Nothing. You do angioplasty, nothing opens. Why? We don't know. Maybe it's thrombus, maybe it is spasm, maybe it's dissection. There's no way I can tell unless I put in an IVUS in this. Now what? So we decided it's thrombus. We had some thrombus in aspiration, so we said, okay, it's thrombus. And we put in thrombolytics. And a few days later, this is what we got. Territory that we've got to work across, you see the thrombus, and you think it is chronic, but it is some thrombus. The history suggests that the patient has had chronic problems and has you can use RTPA, you can use urokinase, whatever you're comfortable. Stage the procedure. Trying to do too much in these small vessels in one go can result in disasters. If we had persisted with angioplasties, thromboaspiration, this, that, and the other, we may never have saved that leg. Okay? Drug-eluting balloons, a word about them. So I am not very comfortable with this. We don't looked at the data. Data is this controlled trials which have been present for this. At standard micro, big enough to be punctured. Where you don't have calcification, you can use access to a combination of the four.
Sanjay Yadav, I'll show you new introduction of bifurcation stent. But
for the introduction and peripheral intervention, I would like, which has immense scope. The objective for Merit, the appropriate solution portfolio. Here, altering this parameter for our coronary devices, closed cell offers better flexibility, and we have the stand 12, 15, and 18 millimeters. Credence bare metal stent platform, which we have designed for Credence cell in the mid segment, a combination of with the help of closed cell design. The platform is shell system O3 starting from up to developing. We were talking about disruptive technologies for bed, and even if the patient comes back for the fifth, indications are going to be stenting, or whether it is in terms of Credence BRS, which is a scenario required a backbone 3 from a biodegradable polymer plant, and this is ideal as soon for a rapid exchange which allows for polymer-free solid lipid nanoparticles, and minimum a morphology modifying device that allows for optimal vessel preparation. In terms of the key parameters for device, it's a new concept in lesion morphology, offer a complete product range.
Actually, continuation on a few places. Meet his endpoints. So similar design for the bifurcation that provisional stenting of the side branch. But we also know in anywhere, and of course then spring of up to 0.5 to 1 millimeter sirolimus eluting stent. The concept there is that how can you cover the side branch from the main vessel, so still have enough room to put a stent in by itself. Most important point. So here from the Triton. The Triton is the same size. Here going to the side branch, 3.5 may become 2.5. And of course more open cell design. So after deployment, put your main vessel stenting. And this is what here, and of course for concept they have done the animal data. This is the proximal, and here through this from main vessel up to 3.5 and side of which we had when we use the Triton in terms of the really will add to that have a bifurcal be as part of the world. Probably you'll follow it through your Merrill sales team. But really exciting. and more what we are learning is that to provide the live, we are ready with the live relay. Okay. So, Roach, you will
Praveen
take
Sharma is
through
doing it or no? I can't
Yeah.
get a clip.
Can we hear it?
We had our expert panel of Sandeep, Nathan, and Dr. Amit Kumar.
Exchange it with that. So we'll show them the angio. Anil,
Vimal,
can you hear me?
a very good morning to you.
Good morning. Is that Rochan
Yeah, that's me. And what are we doing?
in the cath lab? We are lucky that we have a biplane cath lab system here. And we've got a case is about a 56-year-old lady. So we got into the external carotid, parked our diagnostic catheter in the external carotid. And now we are taking a support wire which will help us cross this lesion. Can I go back? Now you
Getting into a stent which is terrible stroke. And I think Vimal,
this balloon there now. Yes,
tissue. There is no plaque.
right. It's a
That
perfect
much
one.
more difficult.
Do we balloon it? Yeah.
Yeah, this.
Number 2 is, should we put a cutting balloon? And obviously drug-coated balloon are another things that we are talking about.
Yes, osteoarthritis is actually the data
Yes.
for drug-eluting and drug coating is very, very sparse because obviously disease is not common in this is one of cell division and proliferation. Theory alone,
Nothing
right?
data available. Yes.
So what about cutting balloon? What do you think? What?
You know, I have used a cutting balloon in a patient with osteoarthritis. Like a crumb. We had an embolic episode, and that was a problem for one of the patient.
Right, that's
So we are not too keen to use a cutting balloon in these kind of patients.
yes. Disastrous in this scenario. You're right.
Hello? Yeah?
So you can see how carefully the
Okay.
manipulations are done in this territory.
So
Up
we
and
have-
see the entire course.
We have a stiff wire in the external carotid.
We didn't hear that. Yes, I mean, classically in the early days
But
when
in this,
you had started your carotid program, Vimal, I remember we used to use an exchange system with a wire parked in the external carotid to get the long sheath
Yes.
up.
Dr. Manish, he's a master neurointerventionist.
Yes.
And we are lucky. And Manish was here. And he's the one who got the balloon inside.
Yeah, this is a situation
So
where the
over
wire,
the
has
wire
to be
once-
through the lumen, true lumen.
Yes. Yes. And now you can see that we've got a balloon which is 7 mm 40.
What
Because the
balloon are you
previous
using here,
stent is
Vimal?
8 mm. We are using a Armada.
Okay.
If-
Showing is,
Yes.
and we're trying to get the
Yes.
high risk procedure. Because of two reasons. When the balloon is
Yes.
inflated, the blood, that's a very, very bad situation to be in because this is inside the.
Right. And the regular carotid we have, yes. We are making a dye injection to see what has happened. I think we'll have to keep the catheter up probably.
Flow
To
seems to have
demonstrate
improved.
that, I think our dye, yeah?
Has the flow improved now?
I'll have to take the catheter up. Now what we are doing is, we are over the balloon and the wire, we are taking the guide catheter at the
To be very careful, and if you manage to somehow engage the stent in the balloon, then you might have a problem there. That's why the guide cath is being taken up, and this is a difficult process. It's a stiff device being taken up.
Now you can see that there is definite
Yeah.
improvement in the caliber.
Yes.
Any case. What we plan to do now, Manish? Yeah.
At the origin still
it
looks
back, yeah.
residual quite a bit.
Yes.
But then
That's right, sir. We are bringing the balloon back
Yeah.
repeat dilatation plan?
and we'll dilate it over there. Out in the aorta is not a worry
Yes.
because the kind of waste coming up on the balloon.
Yeah.
We are at 4 atmospheres, going to 6,
Okay.
10, going up to 12.
And
Yeah, we have gone up to 12 and we're going to deflate it. At this point,
yes,
Ye-
the inflation. If there's any neurological problem
Yes.
occurring, then we'll have to look at why very rapidly.
yes.
In this territory,
And very important, previously we used to have this duck, squeaking duck.
yes, in the contralateral side.
But in this patient, but in this case, we have to keep it on both the sides.
Yeah,
We have a better, but we still want to do one more, right? You
Yeah,
want to do
because-
8 or balloon? Okay. Cutting nail. Dangerous. Cutting, I would, we are discussing amongst us whether cutting any role. I would be little worried on cutting.
thing is there because the tissue which is
And this is one thing we are always worried about in inflammatory arthritis. Because once the
and
wire tip is moving there.
yeah,
The- the original fusion rather than an embolic.
yes, absolutely. This is what is different. Hemodynamic problem
right.
more often, and atherosclerosis is generally an embolic problem. So the treatment is quite different. The philosophy is
Right.
quite different.
Yes, you can see that we are having a tight narrowing there
Thank you.
up to
How long can you plan to keep this inflated?
inflation. No, I think we are keeping in seconds here.
Yeah. Okay.
She's tolerating it though. But I don't think so we should keep it too long, yeah. Where she will definitely have a hypoperfusion. I think we are definitely not gearing up for another stent here. I know some people might be thinking stent within stent. But that will induce,
Yes.
and the next time when we go in, we'll have more problems.
Recurrent disorder. So stents
That's
don't
right.
really improve the long term. That looks better,
Just
definitely.
Not getting a good picture here, though look better. What we're gonna do now, we remove the balloon and we inflate
So that the backflow
and
is
try
more.
and get my guide catheter up inside over it. Now the balloon pull the guide catheter also back.
Yeah, we were just looking at the image, and I think it's important
Yes.
what you mentioned, that you're looking at the flow and not at the appearance of the lesion,
Yes.
because this is never going to
Yes.
be clean looking like a stented result. So, but
सांस बंद रख. Oops. I think the balloon
Yes.
is creating more.
stim, yeah, it's difficult.
Yes.
But even though
It
the
looks
lesion
better.
looks like it's recoiled a bit, your flow has definitely improved.
Because with the a good
Yeah.
Otherwise, she's doing fine. The both hemodynamic as well as neurologically,
Yeah.
she's okay.
We're able to see that on our screen.
Right.
See,
Let us see this picture now. Possibly we will get a. There it is.
oh, that's very nice actually. It looks much better. You're absolutely right.
Yes.
You definitely got a very
Yes.
good result.
Yes. And more important now is that there is a thought process whether to try and open up the right side also. You can see the stump of the.
Whenever you are in the get the perfusion of the areas, and any change in that has to be you get into trouble.
Yeah, this is the town's view. We have the biplane, so we're going to do the shoot in the biplane. Okay. Antiplatelet,
Is patient on steroids or has been on steroids recently?
not really, because her inflammatory markers were all within control.
Okay.
So there was no need for that. In fact, steroid was leading to diabetes, which was going haywire.
Okay. So steroids were stopped. So
Yes,
as you,
so steroid was stopped actually. run
now.
is,
The basilar is seen much
yeah,
better
is
than
it?
before.
Let us see that.
The flow has definitely improved a lot.
Yes, yeah, vertebrals are definitely seen better
The entire
compared
brain
to the
from this
previous
artery.
picture.
Okay.
Yes, fully supported by this.
This, I think if your patient
This
is
patient
asymptomatic
we
now,
will
you'll
be-
be really rewarding procedure.
Yes. We'll ask her to move a leg. दोनों पैर चलाइए जरा. शाबाश. दोनों हाथ चलाइए.
The patient has been asked to move all 4 limbs.
नाम बताए.
And
क्या नाम है?
we'll examine the patient
अच्छा,
neurologically
आंखों में
for
कोई
the higher
problem या
mental
कुछ?
functions, speech deficits, anything at all.
ठीक है. Okay. So yeah, she's managing very well.
So at this point, you're not doing any audience. I think that was a beautifully done procedure.
Which my this one is there. Technology team, Anil and the full gang is here. The nursing staff is here. So
Yes.
everything is looking good. Thank you.
Thank you.
Oh, okay. They want me here.
Excellent.
Yeah,
excellent
thank you very
job.
much, guys. Next time somewhere.
Okay.
Thank you. Thank you.
Thank
Fantastic.
you. Bye.
So I think we
Thanks.
can have a lights and we'll
Yeah.
have a quick, have a little coffee and then come back for the last session of this Merrill 4. Will be on the structural heart disease and tower cases.
Thank you.
Good. So we are not too bad.
Yeah, we are a little behind, but not too much, I think. I think I'll have to take a leave.
Perfect.
I'm supposed to reach Pune.
Oh.
soon.
उधर दिखा रहा है.
Testing.
Here, and during the for ultimately for your tower procedure, and that is what exactly done in this particular case, that patient was brought to undergo core valve tower 29 millimeter, and you can see here the core valve being deployed. If we can get our video in action again, looks like there was some small earthquake. Playing here. So core valve being placed. Now it's not uncommon. Sometimes you have a prosthetic regurgitation. You still have quite a bit of AI. So what you do is you post-dilate. The post-dilatation is done in about 30% of cases, but more so for the core valve, and for the sapien very small. So post-dilatation decrease the regurgitation, which is like happened in this particular case. And of course these cases are closed by femoral pre-closed sutures, and discharge home within 72 hours usually, because temporary pacemaker is left for 48 hours. A patient did well since then and has been asymptomatic from started this journey of the TAVI, using it in cases which were high risk or extreme risk and could not go for surgery. And these are the number of patients, because numerous patients with the severe AS are not getting treated because they considered as a high risk for surgery. And that's where this field is evolving, having two different types of valve which has undergone the trials and approval in the United States, the sapien and the core valve. One is the balloon expandable. Various femorals are not big enough, transapical, direct aortic, or subclavian right or left. Also there are people have done transcarotid or through the vena cava approach, through the vena cava and so. And what has shown that yes, immediately you decrease the gradient significant to almost single digits, and you're done. So where do you decide who should go for surgery, who should go for tower? And so this actually is based on the STS risk score. That is, the surgical risk is a continuum, and what we have seen, the patients with the AS, you can always calculate the risk for them, and they've been the part of the investigation. The first one, we did a trial of patients who were inoperable or extreme risk, where the risk mortality was more than 15. Two trials, partner 1B and the core valve, and basically showed that over standard therapy, the effective decreasing the mortality from 50% to 30%, and of course decreasing rehospitalization, and after 5 years, none patient in the standard therapy is alive, while about 30% patients in the TAVI group remained alive. Then core valve, there was no could not question was high risk. We were 10 to 15, we had two trials, partner 1A, and the pivotal basically showed that numerically, so clearly that initial data having a higher stroke rate were not substantiated in the subsequent trials, and I'll show you who are very sick, very high STS morbidity and mortality. They probably cannot live 1 year, and so there should not be any, maybe just do a balloon valvuloplasty. So clearly we learn high risk, extreme risk, tower is the treatment, and of course if the patients are super risk, low chance of survival for 1 year, should get a balloon valvuloplasty, definitely not the tower. What about the intermediate? And these are the two trials. One is the CERTAVI, which has completed and waiting for the data of the 2-year death and stroke. The one already presented, 2A trial, basically patients were randomized, and then of course and showing that in all groups, mortality and disabling stroke at 2 years was numerically lower in the tower group. So even in the intermediate risk group, now we are having a advantage, and more importantly, if you do a transfemoral group, and then 0.5 of the tower, if you do a family, they're no longer higher. So clearly the tower does not have a higher stroke rate, rather. Now what about the low risk? Now we have the trials for the low risk, which is the mortality risk of Notion, and there are the two trials, partner and Evolute, I'll tell you. The Notion trial, 270 patients, low risk, the curve start here of the higher pacemaker rate is there, and of course, what studies also have shown, the effective aortic valve area with the tower is much bigger compared to surgery. It's largely because of the valve they use. There is an additional cuff, you have to suture it, compared to the very low profile. The tower valve really gives you a big lumen aortic point that even in the low risk. But major stroke at 2 years. So clearly these two trials, which will be done in next 2 to 3 years, will tell us in a large very well. So therefore, if we sum it up, that where we are in this field, that this is the updated, hope have, not only extreme risk, even high risk will become class 1. Here, 7-10 years, there are some with a degeneration of in a single digits, but more importantly, which is coming up now, that there are some, the valve most important is, and phemic deterioration, and this is happening aorta. So you see the position, and then you, of course, is the balloon expandable, you inflate 10 to 12 seconds, gradient is prosthetic against the aortic regurgitation. So there are new valve designs which have a special cuffs around, and the idea is to decrease this paravalvular and the leakage. But as such, valve regurgitation investigated to see, because pure AI, you cannot use the tower valve because the valve will embolize. So these valves have little hooks around, so basically keeps the valve in position. More data about these, more clinical trials. What about the bicuspid aortic valve? Earlier we felt that bicuspid aortic valve is not a good for the tower, but now numerous data actually have come now. We actually ourselves have done about 24 of these cases. So you do leave some prosthetic regurgitation, but in appropriate cases, even bicuspid aortic valve can undergo tower procedure safely. The low flow, low gradient also, a lot of data are coming at present that can be well treated by the tower procedure. So number of the tower actually continues to increase globally. It is said that about 250,000 tower have been 2,000, and 60% is the safe world. Now at Sinai itself, we did last year 201. With the majority, we do a core valve, and of course the femoral. And the key is the conscious sedation. Half of them not even requiring intubation. Just a deep anesthesia, and of course there are some risks which are shown here, but if we make it with the TVT registry, has done extremely well. This year actually the number is almost 28 per month, and we should be over 300 cases. Doing the complex coronary CCC live cases.org, which is the live webcast, third Tuesday of the month, but this is .org. So during which the tower procedure from 9 to 10, it's the second Tuesday of the month and every other month. Next webcast is actually a few days later on August 9th. We'll be using a 29 cardiology long-term benefit, and hopefully what happened in the coronary field, that unless it is a very severe CAD, that piece the cabin.
The TAVR session. I'm going to present a few complex TAVRs that I've been involved with. So I think most of the data has already been presented, so I'll just stick to some that I've been involved with. So this is a case of mitral bioprosthetic dysfunction. This is a 10 years old, dysfunctional due to looking at it from the further proves the hemodynamics that this is a dysfunctional valve. The plan was 10. So when the patient's heart is put through a CT scanner, you get the blood, you a TAVI delivery system with this TAVI right atrium down the left ventricle VA loop with a stiff wire, and the TAVI is railroaded down to the mitral position, and under rapid pacing it is deployed. And this was the very first transvenous mitral valve implantation back in 2011. And this is the hemodynamics pre and post, which shows a good hemodynamic response. And this is just to show you the pre and post simultaneously. You can see a fantastic result with a valve in the mitral position. And that happened to be one of the first transvenous case which we published in JACC back in 2011. Moving forwards to valves, I think Vinay, internal diameter of you can see this is a 33 millimeter diameter of a 33 millimeter epic valve, which diameter of all. This is a epic valve being valved through a transjugular approach to go home the next day. 13. This is a very interesting case I'd like to show. You don't see this very often, which is a continuous aortic regurgitation. What is this case here? RC, LAs are connected together, and then the aorta are connected together. So you have two hearts in parallel circulation. So when you have a donor heart in the thorax fails, and in the native heart. This is just to show you the anatomy. This is the native heart. This is the donor heart. The donor heart's aorta is anastomosed end to side of the native ascending aorta, cardiac output. Over time, the pressure in the ascending aorta is so high that it starts regurgitating this way. And because there is absolutely no systole in the native heart, there is continuous aortic regurgitation. And this is just to show you how bad the native left ventricle is. This is again demonstrating the continuous aortic regurgitation throughout the cardiac cycle. Because of this continuous aortic regurgitation, the cardiac output therefore is decreased because half the blood volume is going back into the native LV, thereby decreasing the patient's cardiac output overall. There was never any treatment for this because patients traditionally went for medical management because they can't go for another transplant, and usually they end up dying because of heart failure. So I thought we can attempt closing this off with a TAVI. So to get some evidence, we did a balloon occlusion of the native aortic valve, did a cardiac output study, and it turned out the cardiac output increased, and therefore it made more sense to close off this echo images with no aortic regurgitation, and the patient's cardiac output increased and has been discharged and is doing very well 3 years down the line. And this was one of the first cases of TAVI in heterotropic heart transplant as a new treatment for continuous aortic regurgitation. What about aortic regurgitation, TAVI and aortic regurgitation in normal hearts? Again, it's unlicensed because aortic regurgitation, you rarely have calcium, and therefore valves tend to slip off. The only valves so far reported to be in place are COVAX series. This is a 40-year-old chap who's waiting for liver hepatopathy and encephalopathy, and therefore this, I thought we'll give it a shot of the vegetation. And the plan was to do a TAVI, and the strategy was to try and land the valve was sandwiched between the sinus. At the same time, filters in each carotid to make sure I'm going to catch it if it does go up. I could try it as many times as I want so that I can get it. We started off the implantation. I'm going to sandwich it, but then because of the lack of calcium, they do slip off, as you can see here. So there you can see trying to implant it in position, and the valve you will see will. But thankfully with the Evolute R system we were able